Welcome to Thursday Thought Leaders with Harbinder Narula on BW Healthcare World. My guest today is Dr. Harit Chaturvedi, who is the chairperson of Max Institute of Cancer Care. He joined Max in 2009 and has passionately built one of the largest and finest oncology programs in the country. With continuous focus on specialization, clinical quality, research and academics, he has steered the team of over 100 oncologists into disease management group, which he calls the DMG model, to help position Max Institute of Cancer Care as one of the most respected brands in the oncology space. Welcome, Dr. Chaturvedi, to BW Healthcare World. Thank you so much for taking out time to be with us. Before I dive into questions, Dr. Chaturvedi, I would be very keen to know that today we have more incidences of cancer that are coming to light. Now, is it because more people are prone to cancer today, or is it because more people are getting screened? So we are discovering more cases today.
So if I look at the population-based cancer registry data, there the wholesome number is not changing. That means that in India, it's about 120 per lakh per year new cases. If I look at a national cancer registry data, it's an average. I'm saying it varies between 60, as low as 60 in some parts of the country, to as high as 340 in some northeast parts of the country. So it's very varied, but I would put that number at around 120 per lakh per year new cases. Now, while this is a truth, the other thing is happening is that there are more and more people moving into the age group of 40 plus. This segment is growing, and as this segment is growing, the total number is increasing. Okay, that is one point. Second is that there is enough data to support that as the economy rises, the lifestyle changes, there is more fat consumption, there is increase in weight, increase in certain life patterns, which leads to growing incidence. For example, in the US, the incidence is threefold higher. In Europe also, it is more than twofold higher. The lifetime risk of getting cancer in India is about 1 in 18 1 in 18 is lifetime risk. Whereas in US, it's come down to 1 in 3 and 1 in 2 in certain segments. So we are at a risk of exploding into that number game in a very unfortunate manner, but there are ways to combat it and overcome it. And that is that the preventive part of cancer is almost 60% is preventable cancer. This is something, if you can do, send this message out before we go on to molecular aspect, this is the key. That tobacco, alcohol, lifestyle, sedentary lifestyle, lack of exercise, more fat consumption, all this has changed the game, and the numbers are going to explode if we don't watch out. Mm-hmm. The positive story is that the mortality from cancer has gone down year on year in the last 30 years. So there's rise in the total numbers. There's incidence in India is almost hovering at the same figure, but looking at the recent increase in the economy and also the overall picture as we are growing, there's a risk that we will explode in a very negative manner.
Dr. Chaturvedi, what is it that people should be doing? Since you said that 60% of the cancers can be, prevented, and I can understand fat and sedentary lifestyle, etc. But what are the other things in the lifestyle space which need to be taken care of by people, which they may not be aware of? They're aware that tobacco needs to be ruled out, but what else?
So one is tobacco, as you rightly said, and people are aware of it, and therefore we are seeing an impact of that. Unfortunately, the tobacco addiction happens in school life, in teens, in the age group when one is in teens. It doesn't happen once you're in office and you're in workplace. About 20, the incident, new pickup is very limited. So that is one area. And while people know that tobacco is harmful, by the time they know, they are often addicted to it. So many doctors are tobacco addicts because of the reason that they got into the habit early. It's an addictive thing. So knowing has helped in bringing down the overall pickup rate, but it is not where we are. Should it be banned? Should it be nearly banned? What is the status? That is something we'll discuss some other day. So tobacco is an important factor. Then lifestyle. Now that includes, again, junk food and the habits which you pick up in school life and in early age, And that is also going to have a very negative effect. Recently, we did this Max Cancer Congress, and there we had a session on preventive oncology. And there we had some 40 odd school principals. And all these school principals from so-called elite schools, they also have a section for EWS children. And they said that in the interval, the food which the so-called students from the good background bring, the lunch they bring for themselves, is not eatable compared to the food which is brought by the so-called economically weaker section people, because that is more healthy, more raw material and grains and food, rather than something which is highly cooked and preservatives used and all those things. So the point is that we are exposing our kids to all these habits very early in age. And when we want them to leave it, it's not easy to leave. They're already addicted to it. So whether it's tobacco, whether it is lifestyle, then again, outdoor games versus smartphones and playing all these games on the videos all the time and feeling your thumbs are exercising and nothing is moving in the body and you are tired at the end of the day. And that has double effect. Today, we are seeing so much of screen usage. In fact, 2 days back, I read this article, and most of us have seen that this is leading not just to depression and other impacts later in life, that the usage of digital screens early in life, that it is going to have what I should say, epidemic kind of a phenomenon gradually, because it will lead to insomnia, poor health, including lifestyle. So this is something which we need to catch on early. Grains in food are important. Colored plates are important. About 3 hours of exercise per week is important, whether you do it in 5 days, 60 minutes, 6 days, 40 minutes, 7 days, 30 minutes, your business. But at the end of the day, if you are on the exercise for 30 minutes, 3 hours in a week, that should take care of some aspect of your health. And few things, for example, delayed pregnancies and nulliparity, this is also on the rise. We know that the fertility rate has gone down globally. And so we cannot comment on that for a person, but as a society, we need to be aware of this. What is the healthy age for each activity and how we can incorporate or drive towards it. I'm not saying that I'm not going to advise to a lady or to a person that start your life at this age. Even my children don't listen to me. So I have no business to advise as to anybody. But at the same time, as a society, we need to answer these questions, that how we solve it for it. While professional journey is important, the growth at a certain point is important, investment is important, but this also should not wait. The biological clock is clicking. How do we fix this and marry the two together to create healthy society for the future?
That's a brilliant piece of advice that you've given, Dr. Chaturvedi. Dr. Chaturvedi, technology has advanced today, and this is true even for conditions like cancer. And how has cancer treatment evolved over the past few years when we see genomics and precision medicine, etc.? Now people are even aware of it, that they are more prone to cancer than anyone else because of their genetics. So can you share some light, throw some light on this, sir?
Absolutely. So I'll just take you back from the time when I came into oncology, and then I will come to where we are today. So when I came into oncology, even FNAC or needle aspiration cytology was not so common practice. So that means the diagnosis of cancer or the understanding of cancer in clinical practice was very limited. It was good in the labs, it was good in the academic environment, but it was very limited in clinical practice. The mapping of cancer, I refer this in two ways. The understanding of cancer and the mapping of cancer, both have changed dramatically. The imaging and all these facilities have changed in a huge way. So to the first part of the question, that understanding of cancer, a lot of people thought was one disease. Then we realized cancer has got, depending on the organ and the type of cancer, there are multiple diseases. Then within that organ, we realized, and within that type, we realized there are certain variations which came up by immunohistochemistry. And then we saw that no, breast cancer is not 2 types, it is 50 types, because ERPR, HER2, or luminal A, or luminal B, or luminal C, all these are different subsets. So we came there, and then we said that, okay, this has to be planned in 3-4 different ways. For example, a T2N1 breast cancer, which is triple negative, is treated differently from a ERPR positive HER2 negative, or treated differently in low KI and high KI in different subsets. So then we realized that, breast cancer is now 7, 8 different types, which you fine tune. And now with the help of understanding of mutations and what happens within the tumor, I'm talking about mutation within the tumor, not the genetic mutation. That is different. I'll talk about it later. But within the tumor, there are certain mutations which happen, which expose the tumor to be treated in a targeted manner. Those mutations can be targeted by the medicines directly. And this is called what is precision medicine today. Understanding precisely where the mutation is happening, or understanding precisely that the tumor cells have covered themselves with certain mechanism which is preventing the immune system of the body to attack the tumor. If you uncover that tumor, the immune system of the body will take care of that. Just the other example. The one is the targeting, the other is exposing the cells to the immune strength of the body. So these things have made it possible to give treatment which will directly affect the tumor and not the healthy cells. Okay, and what happens? Tumor almost behaves like an organ within an organ, organism within an organism. So what is happening while we are attacking this mutation? Some another new mutations come up. So it is trying to escape the defense mechanism of the body, and then it outgrows that again, and then you target that again and precisely attack that. So this has led to huge advancement and a lot of opportunities for research and targeting the tumor precisely. And every week about 25, 30 new drugs or molecules, mainly using targeted mechanisms to attack the tumor precisely, preventing the normal body so that the quality of life remains good and the person is able to live a healthy life while the tumor is being attacked precisely.
Right.
Now, and you also asked about
genomics, sir.
Genetics. Yeah, genomics. So genetics is something which runs. So this is what is called germline mutation and somatic mutation. So what I was referring to was somatic mutation. That is mutation which happens within the tumor. The germline mutation runs in the family. There are certain syndromes, certain genetic mutations which are carried forward to the next generation, and therefore they are more prone, and we can identify that high risk category. We can modify their life. We can also advise to them what preventable action can be taken at an appropriate time so that the cancer does not happen. It is prevented from happening, or at least detected early in time so that can be cured with a very good success rate. Now, I want to emphasize that this germline mutation, which runs in families, is not more than 5 to 7%. So my message is, earnest request is that we should not associate cancer as a familial or a hereditary disease. We should identify the risk groups. We should relate this with the identified risk and to be managed accordingly, and not as in a general way. Not in a general way.
Got it. Got it. And sir, before I move to the next question, I had made a list of questions. I think you had received it. What is molecular precision medicine? Do you think you have answered this in your answer right now? It is separate.
I will go into more detail if you want that.
Okay, great, sir. So I'll ask you this question. So Dr. Chaturvedi, what is the can you explain to us what is molecular precision medicine per se?
Yeah. So as I mentioned in this thing, that the mutation happens at two levels. One happens in the tumor cells, and where we are able to expose or rather target the mutation which is causing. So a lot of times we see a long list of mutations. Now, long list of mutations cannot be targeted, but there are certain things which are the driver mutations, which lead to the series of mutations. So we have to identify the driver mutations. So today, when we sit down and discuss a treatment plan, it is not just limited to surgical, medical, radiation oncology. We want people from the genetics and molecular background as part of the tumor board team who help us identify which is that mutation which is leading to the rest of the mutations. So if you target that particular mutation, it will lead to a better outcome and control of disease, rather than trying to look at all the mutations and then trying to figure out what will be appropriate. So this requires the full understanding of the tumor biology, and also in each given situation, this may be of different importance. Sometimes we have medicines which are possible to target a particular mutation. A lot of times there are no opportunities there as of today, but new research is helping us relate with that and identify. The major area where we see this happening in a very big way is lung cancer, for example. So stage 4 lung cancer, when we started, was almost like a death knell. Today, good 12 to 15% survive beyond 5 years, which was beyond my expectation. And because there we have got targets, we have got identified mutations, and where we can treat them appropriately with a good quality of life. So that is one of the areas. Likewise, in breast cancer, colon cancer, and a lot of other areas, we are seeing renal cell tumors, melanomas, head and neck cancers, where we have got now and this thing immunotherapy, which is making a big impact. So all this has collectively shown a very positive trend, even in advanced cancer. So one success story is that treatment outcomes have improved in early cancer and mid-stage cancer or locally advanced cancers. The other good story is that even advanced cancer, the opportunity is not fully lost. There's no such thing as complete loss of hope unless we have analyzed the tissue properly, unless we have discussed that whole thing in detailed manner with the relevant team to make sure that the person has been identified for that unique situation. Every tumor, every person may be having a unique situation. If that is identified and targeted, a lot of times it is possible to treat more aggressively and appropriately.
Right. And Dr. Chaturvedi, why is it important for healthcare professionals to stay up to date with the latest advancements in molecular medicine today? Because a lot of people, a lot of doctors, they come in, they get so busy in their schedules that they don't take time out to go and update themselves. So, what is the importance that you feel is there for them to remain updated?
So you have hit the nail at the absolutely at spot on, because what happens, as I said, no, today in tumor boards. So tumor board is a platform where the clinicians are supposed to discuss their cases within the team. What is the best plan for this patient? And as I mentioned, today tumor boards are not complete just with surgical, medical, radiation, oncology, radiology, pathology, but very important is molecular and genetics aspect of it. Now, if you are not updated, few of us, I may be frozen in time in 1992 when I did my MCH, or 1993 when I did my last so-called qualification in oncology. But if I'm not updated, I'll be giving advice which was relevant in 1993 while the world has moved to 2023. So how relevant it will be, it's anybody's guess, and I don't have to elaborate on that. So it will be almost, I would say, criminal to be living in those times and practicing today. If you are practicing in today's times, you'll be practicing today. Now, how do you make it possible? It is not possible by doing everything, running from idea to do it. It is possible by having a structure where you have regular meetings, where there are students. So a lot of good things have happened over the years. For example, DNB programs, teaching programs, all private hospitals. We have a teaching program in every department of our hospital. So teaching programs not just bring students, they also bring thesis, they also bring questions, they also create an ecosystem where there are young faculty, there are old faculty, and all sitting together and discussing. So that makes it a thriving environment. The other thing which I feel very good and I feel very strongly about is that conferences and meetings and seminars. So when we go there, when you prepare for a 10-minute talk, you invest 30-40 minutes at least for those 10 minutes. And you expose yourself to those 100 people for questioning, answering, and all those things. So for both the sides, it is important to engage on these platforms and see what is new, what is forthcoming, what is the direction. So as you said that how important it is, I think it is unprofessional to be not up to date. Being up to date does not mean just knowing the basics. Being up to date means that you are current edge. And a lot of times today, even patients educate us. They have done a recent Google search and something out of the box comes out. And that question also, I feel very excited about, because a lot of times these questions give us opportunity and new direction to think. So it will not be appropriate to do anything today without current age practice, understanding and application. And that is only possible through regular tumor boards. We at Max have consistently believed that every patient should go through the tumor board. Not necessarily always before treatment, but sometimes even after treatment, because that also helps in building it. You cannot hold a patient for a treatment if there's a straightforward situation. Or I can have a consultation with my colleagues in an informal way, not in the tumor board, while we are discussing in the OPD. but the tumor board is a formal way of making sure that all the data has been looked through and discussed. So we worked with certain organizations to build a rather Dig Onco. We created a Harmony platform. That's a Harmony platform is a software built for tumor board discussion. And that has helped us a lot because that seamlessly brings in all data from the system to bring on single screen and so that everybody can discuss in a very transparent manner.
Right.
So that's very helpful.
And Dr. Chaturvedi, is also the artificial intelligence playing a role in terms of learning from past cases to bring intelligence to what you can do today?
So AI is playing, I would say today, almost 10-15% role in modifying treatments, but the opportunity is much bigger. As you said, old data, analyzing what is the best practices. So all of us have heard of IBM Watson, which was brought in with this belief that all the data analyzed and current literature and the recommendation will come. But it did not succeed to that scale which was expected because of various reasons, including that the data was limited from a couple of institutions and the literature anybody can do the search. But today on AI platforms, a lot of search engines have been created from all the old data and recommendations, current literature. So today the clinicians, and I would take name a few, for example, Navya, Onco.com, and a few other platforms which give second opinions driven partly by AI and partly by clinical input. But together, an ecosystem is getting created where the old data analysis will help us and guide us what works and what doesn't work. More importantly, I feel it will also help us. For example, I talked about NGS and the genetics, the mutations. Now, AI platforms are important to help us analyze those reports. It is very difficult for a clinician or for a molecular oncologist also to be able to go through all the data and not commit an error. So AI will help us sift that out, come out a couple of relevant points, and then take a good call on that. So on the move, this is going to be very valuable. On the move, this is going to be very valuable. And on one side, we all fear that what will AI do? Will it surpass human abilities or where we? I think we should all have faith that our collective wisdom will make sure that it is used for the good purpose, and we should be able to manage when it's going wrong. But yes, I also share some thoughts on what may go wrong on that platform.
And Dr. Chaturvedi, you spoke about molecular precision medicine, and you spoke about how it is going to impact, the treatment of cancer. But there are no developments that happen without speed bumps and challenges. So, what are the challenges in implementing molecular precision medicine? And what do you think is the potential it is holding in improving the cancer treatment for the future?
So challenges like adoption of any new information, new technology, those are embedded in it, that the adoption is poor, the learning is poor, the understanding is poor. And a lot of times people have this fear or rather instinct of applying what is so obviously looking in front of us, but not able to deeply analyze the whole thing and know exactly what it is good for the given patient in front of them. Having said that, I think the opportunity lies in creating a lot of layers of conversation at all levels regarding this, regarding the molecular and precision oncology across institutions. Today, these conversations are limited to a handful of centers because the cost of the test is very high, the cost of medicines is very high, so it's almost like irrelevant for a lot of almost 90% of our population. But that irrelevance will become more and more relevant as we'll apply more. So these things are very crucial that we build those conversations and make it happen. I think in UK and some other parts of the world, developed world, there are mass-based genetic analysis going on. So the Human Genome Project, which led to the analysis of human genome by a lot of lab, that gave a lot of inputs to every aspect of healthcare, and this was also partly came out from there, that what is happening. I think likewise, we need analysis for all cancers across society, across our different economic and social systems, so that we get to the real common data denominator. That will help us build an algorithm, or that will help us build a system where we can analyze every tissue and get appropriate answer at early time rather than delayed. That will be helpful.
Right. And Dr. Chaturvedi, how can the government help doctors, both in public and private practice, gain expertise in molecular precision medicine? Is there some programs that they run? Is it that something that they're doing to promote this?
So again, I think this morning I got an opportunity to talk to somebody senior in government, and I messaged to him that I think there are a lot of places where in oncology we are not using IT adequately. For example, in access, in terms of penetration and reach in the what I call the ground shoots, ground shots, that we what all we can do in preventive. I was talking more about preventive and early detection, all even at the grassroots level in villages and everywhere. If we club all that in common government platforms, that what all one should do or not do, or how to practice, how to evolve. Likewise, in advanced, the other end of the spectrum, advanced medicine. There also we can create platforms sharing this knowledge across oncology communities and centers. This is not impossible today. Actually, this is something which the government can do easily, and share that platforms and knowledge so that the adoption gets faster. The cost will go down rapidly if the adoption goes faster.
And Dr. Chaturvedi, what are some of the misconceptions related to molecular precision medicine that the patients and their caregivers have in their mind?
So I wouldn't say misconceptions. The fear is that partly the cost is high, which is I agree with that. One is that a lot of people are not aware of it. Even as I said, that 80-90% of our oncology community also feels that out of reach because of the cost factors. So for them, my advice or opinion is that please keep looking at it, keep messaging whatever you can. You may not apply it today, but tomorrow when you have a chance, you will still not apply because you have kept it out of your room, out of your sight, and that is not very helpful. Second is that each time we build this and work on this, we actually in some ways make the cancer weak. In some ways we are able to find solutions, and in that thought process some new thing will come up which will be more helpful and most cost effective. So common people think that is beyond us all the time. I think that thought has to go away. We have to build that conversation. We have to create platforms for cutting down the cost. We have to create platforms where people can be supported even for molecular and precision and immunotreatment, so that they can actually get the benefits of the best. And in next 4 or 5 years, this will hugely impact the overall picture.
And Dr. Chaturvedi, as an oncologist, what are the cancers that you think can be effectively cured by molecular precision medicine?
I would say first is what can be prevented, and for prevention, other than what about we talked about lifestyle, the genetic understanding of cancer will help us identify the high risk group, and there we can do aggressive screening and apply prevention in a more authentic manner. Today, for example, we do much more number of BRCA testing and breast and ovarian cancer screening, but in practice we at max do almost 20 odd cases in a year. We do preventive surgery for oncology. Now, this number can also go up because more and more people can be identified and therefore lives can be saved. So this is one part. The second part, I would say the adoption for public at large would be, as we discussed, that the understanding as we percolate in the masses that this test should be done and then identify what is doable and not doable may be of greater help and value.
And Dr. Chaturvedi, is there a possibility of cancer relapse with such treatments?
Cancer relapse is a risk anyways. I talked about the organism within an organism. So even when you're doing precision medicine and you're targeting the tumor is finding out ways to circumvent that and redevelop. So this happens after surgery, this happens after radiation, this happens everywhere. Likewise, in precision medicine also it happens. It's not because of precision medicine, it happens anyways in cancer, because cancer cell has two unique properties. What makes it an immortal cell? It happens in immortal cell because of its ability to multiply endlessly. And second thing is even at the cost of the host. It will come. So a benign tumor will stop multiplying at a certain point, but a cancer tumor will continue to multiply. And second is its ability to thrive in in hostile situations. For example, a breast cell will not survive in a healthy liver, but a cancer breast cell will survive in a liver, in the healthy liver. So it has the ability to multiply there also. So it is the innate character of cancer that it has the tendency to relapse. It has a tendency to come back. It has a tendency to strike in unexpected locations and unusual pictures. That all is happening all the time. Having said that, precision medicine has answered a lot of these questions in a very positive way. And I see a lot of hope in that because it works across and it can make a big difference. The best way to prevent relapse is to detect cancer early. If in a general way, I would say a stage 1 cancer has almost 90-95% cure rate or lack of relapse in 90-95% of patients. If you put this across stage 3 or stage 4, where the relapse rate is somewhere in the upwards of 60%, 70%. So detection and screening will remain the main tools for fighting cancer. Awareness, detection, screening, all that. Whereas even advanced cancer, advanced medicine, precision oncology, all this will change the game and is changing the game every day. So both the spectrums are important and both are getting impacted by the new knowledge, understanding of genetics, molecular, lifestyle, and all these things.
Dr. Chaturvedi, thank you so much for your time. This conversation about molecular medicine and its role in oncology, I think is really, really, bringing out the technological development that we are seeing today in the field of oncology and the difference that it is making. I mean, it is very encouraging to know that what percentage growth we have seen in the number of people who are surviving cancer today, which is very encouraging. And secondly, your views on the importance of keeping yourself updated is a responsibility of the practitioner to ensure that you are being professional. Like you said, it's unprofessional to not be updated. So a very beautiful thought process. Thank you so much for your time to speak with us today.
Thank you. Thank you.